Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello, thank you for joining us for today's webinar, Pre-Claim Review, Lessons Learned, where we will hear that success is in the details. My name is Molly Casey. I'm on the marketing team with Axxess. Axxess is a leading home healthcare technology company offering a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. Joining us today is DeAnn Briscoe from Mac Legacy. She serves as Senior Director of Clinical Education and has worked in the home care industry for over 20 years. Her current responsibilities include the planning, development, implementation, and evaluation of continuing nursing education activities. DeAnn has developed and written many home health care educational programs and provides training for many home health agencies. Mac Legacy specializes in solving complex problems and turning them into simple solutions for home health and hospice organizations. They provide coding, expert consulting, education, and tools to help organizations compete in a difficult marketplace. Presenting with DeAnn today is David Hoover. He is the Vice President of Revenue Cycle Management at Axxess. He leads the company's billing, electronic data interchange, and payer management service teams. To date, David's team has processed more than $14 billion in Medicare and managed care claims. Prior to joining Axxess, David has served in a variety of roles in the healthcare industry, providing operational and financial expertise. Before we begin, a few housekeeping items. Your phones have been muted, but you may submit questions through the question function. We will follow up with you after the webinar today to respond to any questions you may have submitted. Slides from today's presentation, along with a recording of the webinar, will be available after the webinar and will be sent to all who registered via email. They will also be posted in the Axxess Help Center. Just a quick note, we have also posted the PDF of the slides for today's presentation in the handout section. Okay, DeAnn and David, over to you.
Thank you, Molly. I appreciate it. And welcome everyone. And we are going to start and have a brief conversation about pre-claim review and kind of what we've learned so far. Again, with COVID and some of the pandemic situations, it's been a little spotty. So one of the things that we wanted to start off first is kind of like a little review of what pre-claim review and our review choice demonstration is. So we'll start with that, and then we'll get to some of the lessons we've learned. So why is review choice happening? Again, remember that pre-claim review actually started way back in 2016, was delayed a little bit, and the real reason that it started was to try to make sure that CMS was working towards prevention and identification of potential fraud, waste, and abuse. So again, it's trying to make sure that some of the things and the claims that were coming through, especially for the 5 states that fell under review choice demonstration, and make sure that the claims were going through appropriately and reviewed appropriately. So just a reminder, Illinois, Ohio, North Carolina, Florida, and Texas were all in this 5-year, and really it's an intervention period when we're talking about review choice demonstration. So again, prevent and identify potential fraud, waste, and abuse, protect Medicare trust fund from improper payments, and then also reduce those appeals that come through for Medicare. So going back through some of the dates, just a reminder, because this has been altered and changed, so I'm just going to give everybody a quick timeline. Back in April of 2019, CMS actually received approval for RCD. This is after the delay in the pre-claim review. Shortly after that, the Illinois selection period began. Illinois had already participated in pre-claim review, so it was fairly familiar with what was going to happen and go on, and so they were quickly brought on to RCD. Excuse me. In June, Illinois actually began RCD. Shortly thereafter, in August, the selection period for Ohio began, and then Ohio began RCD in September. In October, late October, October 21st, CMS delays Texas, and really it was due to PDGM. This was after some efforts with CMS and legislature to not burden the home health agencies with both dealing with RCD and PDGM at the same time. So, and then shortly after that, in March, the end of March, the CMS paused all RCD activities due to the COVID virus. Once that occurred, we went through a couple of different announcements, and then in July, CMS announced that there would be a resumption of RCD. And when they paused RCD, they really decided that they were going to leave it up to a choice. They weren't going to enforce any penalties or any of the activities if there was not information on the claim related to RCD. But most everybody kind of continued on if they were in the process of RCD to try to do those pre-claim reviews. Number one, it makes sure that the claims don't have to be reviewed post-pay. Also, it allowed them to move to that second level of RCD, which we'll talk about shortly. In August of 21, CMS announced a phased approach for 60 days to resume RCD. And then we just found out last week, last Thursday, I believe, that CMS extended that phased approach until January 1st of 2021. And basically the phased approach is restarting, so they are allowing and continuing to do and accept RCD as it stands, but they're not penalizing anybody for not participating at this point. So just a real quick review of how the choices and what's out there. So once a home health initially selects a choice, there's choice 1, which is actually a pre-claim review, choice 2, which was a post-payment review, and then choice 3 is actually a reduction in payment, and that is the default. If there's not a choice chosen, that was the default. So most people have done the choice 1, which is the pre-claim review, which is submission of documentation and information, and you get affirmation, and you receive details to put on the claim so it can process through. If you get, after 6 months, if you get the affirmation rate at 90% or higher, you actually can go back in and choose additional choices, a selective post-payment review. So that is MAC reviews every 6 months, and that's really just a sampling. And then a spot check, MAC will select 5% of home health claims every 6 months. So getting that affirmation rate is important because it takes the burden off of the agencies by being able to move into these secondary choices that are there. So just a quick review of each one of the choices. So all episodes are subject to the pre-claim review. There are unlimited resubmissions are allowed for non-affirmed decisions. So if you don't get the affirmation, you can submit those after that as many times as you want. More than one episode of care may be requested in one pre-claim review. So most people are doing that, especially with PDGM. They'll do both episodes of care. They'll receive that UTN number up front so that they can have that happen initially and not have to worry about it subsequently in the next episodes of care. And then claims associated with provisionally affirmed requests will not undergo any other further medical review except if there is actually a situation where they believe that there is fraud occurring. So choice 2 is a post-payment review. So 100% of the claims are reviewed after final claim submission. This would be typical to like an ADR type of situation. Update on 1/6/20, this is the default selection. If no review, it was updated on 1/6, and this is the default selection. So I apologize, the one was not before. Once the claim is submitted, Palmetto will process the claim for and then ask via ADR for the home health to submit additional records. If a response to the ADR is not received, an overpayment notification will be issued after each 6-month period. And this is a claim approval rate, which will be calculated and communicated to the home health agency, moving into those additional choices. Choice 3 is the minimal review, but there's a 25% payment reduction. And so all claims have a 25% payment reduction if there is no other choices here. This one basically is kind of doesn't allow the MAC or to get involved with the claims beforehand. So subsequently, they're taking that reduction, basically assuming that everything is not in order, so that they can go back in and potentially look at a RAC or a targeted a TPE review afterwards. And providers who select this option remain in this for the 5-year duration. So this was not a popular choice. Once you get past that first group and you move into the second group of choices, you have the selected post-pay review, and that's a random review every 6 months. And the provider remains in this section for the remainder of RCD. And then the spot check selects 5% of home health claims every 6 months, and then we'll send ADRs and follow CMS prepayment review procedures after that. So again, this is a quick just catch up of everything that's going on. And I know that we have multiple people in multiple different stages of RCD, but it's some of them, it's very good because we've learned over the past 1.5 years or so what to expect and some of the consequences of doing partial or non-affirmations. So DeAnn, would you like to continue and talk about some of those?
I sure will. Thanks so much, David. What I wanted to do today is take you through the real life scenarios that I've been seeing with RCD and mainly the problem areas. For each problem, I have some strategies you can utilize. And although I'm approaching this from a PCR perspective, which, as David said, that's overwhelmingly the most popular choice with the review choices, these issues that I talk about are not just issues of prepayment, pre-claim review. They're also issues of post-payment review and the minimal review choices. So if you're not in the PCR camp, this is not a waste of your time, is what I wanted to say. So the issues I'm addressing are not in the order of occurrence. Just wanted to let you know that. In my recent experience with submission of PCR for other agencies, it seems to ebb and flow in the problems that arise. You know, one week you'll have a lot of face-to-face issues, and the next week it's signature problems. So first, we're just going to talk about signature problems. I know it seems like an amazing fact, but I am still seeing stamped signatures or an electronic signature that may be electronic, but it appears to be stamped. So here's the bottom line. If the physician or the practitioner, their signature looks exactly the same page after page of the plan of care or on the face-to-face or any other order that you have, it has to be either electronic or stamped. Now, stamped signatures were basically outlawed many, many years ago. And then recently, CMS has said that there are rare occurrences when the stamp is allowed due to civil rights reasons. But honestly, I've really never seen it used for those purposes. An electronic signature has to have a notation that it is electronic. Now, I'll just tell you that there are maybe 50 or more different options to designate a valid electronic signature. And I really guessed on that option. I didn't really count them, but it just seems like there's a whole lot. So you're going to want to look at the documents I've listed here in those last few bullets and see, look at those documents so that you will know all the options that are allowed. I didn't want to go through each of them. Okay, you can progress now. Next slide. Okay, so really, I've already given you one strategy, the documents and how you tell if they're electronic. Personally, I have them printed out in a notebook that I consult when I can't decide if the signature is valid, because as I said, there are many ways that CMS and Palmetto GBA have come up with the verbiage of a valid electronic signature. But here's my number one advice on this matter. You have to examine all your physician or practitioner signed documents when they come into your agency. And human examination by a knowledgeable human being is the only way to ensure that you have a valid document. Any document that's found to have an invalid signature will be treated as if you didn't even submit it to Palmetto. So when I say a knowledgeable human being, I mean someone who knows who is eligible to sign and what their other signatures usually look like, if possible. It's difficult for physicians and practitioners to keep up with home health regulations. So you must help them understand and educate them on what is needed on your side. If you get a signature that looks stamped, have the practitioner hand sign next to the invalid signature as soon as possible. Or in some cases, I've seen agencies who were using electronic signature method to have that software send some explanation of this is a legitimate signature. So just depending on what you're using. Also, examine your agency policies and practices. If you utilize a signature log, you can send it with your submitted documents to prove the eligibility of the signature. Now, another problem that has arisen since the public health emergency seems to be the practitioner or physician's credentials. And I'm starting to see signatures, particularly of nurse practitioners, physician assistants, and those eligible practitioners, that there's a signature, but there's no credentials anywhere on the document. So we know the regulations tell us exactly who can write orders for home health care. And when there's no credential, you're just left to guess if they're eligible. So in this case, we've used the MPI registry website to verify what kind of practitioner that person is. And we send the documentation over with the other submitted documents. So it shows that it is a nurse practitioner or a physician assistant. Okay, you can advance the slide. So let's look at another issue that has been plaguing us for years. It's the face-to-face encounter. And of all the home health regulations in my career, at least in home health, I believe this is the most difficult one that has ever been written, at least that I recall. So let's try and work through the common problem areas. Everyone is pretty well up to speed that an actual face-to-face encounter document must be included in the establishment of eligibility of that patient. So this entails a patient in front of the physician or the practitioner where they have both a verbal and a visual encounter. Encounters by telehealth must be both audio and video. Although I've seen a few that don't have the video, the overwhelming issue is with face-to-face is the reason the patient saw the physician or practitioner and the plan of care primary diagnosis. So the primary diagnosis on the plan of care doesn't have to be exactly, they don't have to match exactly the documentation in the encounter. But the problem listed as primary on that plan of care must have been addressed or at least inferred to in that face-to-face. Not just that the patient has a history of that issue, but the problem was assessed as a current problem. So that's what you're looking for, current problem addressed. So let's look at another problem. The face-to-face is not performed within allowed time frames. And the primary issue I see with this is a patient who has been discharged from home health for a period of time, and the previous face-to-face documents still live in your clinical documents. And what I've seen in one particular agency that we're submitting for is that it's very easy to get confused and accidentally pull up that old face-to-face into your current documents for submission if you're not very careful. So just be very, very careful depending on how the software is organized, which I will say that Axxess has a very good grip on their organization of documents. So you can advance now. So let's look at some strategies. Just like I stated with signatures, have somebody that's knowledgeable examine the face-to-face as soon as it arrives in your agency. I suggest a clinician because of the simple fact that they have probably seen more progress notes and hospital notes in their career than any other non-clinician. You need someone who can quickly say, something's not right here. So a face-to-face that is ineligible will just totally stop your RCD progress dead in its tracks, and that ends up costing you time and money. Also, make sure your coding and clinical personnel have access to that face-to-face to ensure they're on the right track with the establishment of the primary diagnosis. In the event you have a face-to-face encounter and a plan of care primary diagnosis that don't relate, you have a couple of options. You could go back and change the primary diagnosis of the plan of care, if that's appropriate. You know, get it re-signed by the physician or the practitioner. You could also seek an alternate face-to-face encounter. So just remember of those time frames that it must be performed within 30 days after the home health start of care or 90 days prior. So if you need a new face-to-face, you could ask the patient to go back to that doctor and get a new face-to-face. Or you could ask the ordering physician, is there any other documentation that might be used as a valid face-to-face? Because what we do is we ask these referral sources for the face-to-face document, and sometimes there's many to pick from, particularly if you have a hospital referral. You might have days and days of documentation that could be used as the face-to-face. So one of the other issues that is fast emerging as a problem is coding guidance versus the primary diagnosis. And one example of recent non-affirmations have been due to the diagnosis of hypothyroidism with a secondary diagnosis of dementia. Now, when it's evident that the documentation that's in the patient's chart is the problem is dementia, when that's the reason that you're going to see the patient, but the coding guidance requires hypothyroidism to be coded first, you can have a problem. And I think other issues like this may be coming up in the future. In the case of the hypothyroidism issue, we have begun a strategy to send coding guidance as part of our supporting documentation in hopes that the reviewer will not assign a non-affirmation due to that diagnosis, because coders are, need to follow their guidelines also. So it makes it a little bit difficult. This is the first one that we've been seeing the diagnosis come up, and I don't think it's the end I don't know which one will be next, but just keep in mind, if you ever get denied for a diagnosis and you can show that there's guidelines for the coder to code one thing above the other, go ahead and send that documentation to the reviewer. Okay, advance, please. So here's a little fun activity. This is a little test of your knowledge so that you're picking up what I'm telling you. And here's a real life scenario that happened recently to me. So your home health plan of care has a primary diagnosis of encounter for adjustment and management of venous access device. And by the way, I always look, when I'm reviewing my documents for submission, I always look at a plan of care diagnosis before I look at the face-to-face when I'm reviewing. So, I have in mind, that primary diagnosis on the plan of care was that encounter for adjustment and management of the venous access device. And so I'm going to want to see something about that in the face-to-face. So then you go to the face-to-face document. And in this case, there was documentation that the patient was seen for stage 4 breast cancer and complications of chemo. And she also had hypertension and depression and, various other issues. Now, in the physician's face-to-face documentation, in the narrative part, he stated that the patient continues to receive TPN at home, total parenteral nutrition at home. And another thing he charted was the patient needs a wheelchair and has a history of falls. Okay, so what do you think? Does this patient need a different face-to-face encounter, or is this one going to pass? So I'll give you a couple of seconds to think about it, because that's all we have. It's a couple of seconds. And I'll have you advance, David. So hopefully you got a minute to kind of think this through. This is one of the reasons I'm in favor of a clinician analyzing the face-to-face when it arrives in your agency. Because most clinicians, most nurses at least, would be aware that TPN can only be given intravenously. So, because the physician documented the patient is currently actively receiving this therapy at home, the face-to-face infers that there's a relationship between the primary diagnosis of encounter for vascular access device and the plan of care. So my conclusion is that the current face-to-face is valid. And in fact, although I was nervous when I submitted this one, it did pass the reviewer scrutiny at Palmetto GBA. So this was a very tricky one, but hopefully you passed it well. So you can advance again, David. Okay, so now let's talk about a different issue, and that is the face-to-face certification attestation, or it could be the certification statement. I kind of vary between what I call it. I have seen lots of problems with this. Now, just as a reminder, you need a face-to-face certification attestation when the practitioner or physician who signs the plan of care is a different person than the one who performed the face-to-face. So what we've been seeing is there's no face-to-face certification on the plan of care or on a supplemental order. And this will result in a non-affirmation when you have two physicians or two practitioners involved. One did the face-to-face, one signed the plan of care. The other common issue is the date listed on the face-to-face certification statement is different than the actual face-to-face encounter. See this all the time. So what I'm saying is, if the face-to-face encounter was performed on September 2nd, 2020 by Dr. Black, and then Dr. White is the signer of the plan of care, there has to be a face-to-face certification order, because that's two different practitioners. Now that certification order stated on the plan of care or a supplemental order must say that it occurred on September 2nd. And it's so easy to get that messed up, particularly when your referral source has sent you, pages and pages of a hospital note, progress notes, and you haven't really decided which one you're going to use as the face-to-face document. Okay, go ahead and advance the slide. So let's look at the strategies for this. If at all possible, include the attestation statement on the plan of care. And here's an actual example that I snipped from a plan of care that works just fine. Sometimes you might get more than one document that you could use as a face-to-face encounter. And I've talked about that, particularly if you've had a patient that's been in an acute care facility and then they went to a rehab. I mean, you just may get dozens of documents. So be sure you know which one you're going to use, as I said, so that your dates can match. Also, I see agencies getting face-to-face attestations when they don't need to. They just do it just in case without really understanding the rule. And this causes a burden of time on both the agency and the practitioner. Also, if there's a note by the plan of care practitioner that says, I saw this encounter and I agree with it, and there are signatures and dates and credentials that I'll talk about in a minute with signatures, is you don't really need that order. So just look at it very carefully to see, do I need a face-to-face certification attestation or not? So now you can advance the slide. So here's another one of those little test your knowledge. So this is exactly the way I write my notes when I'm reviewing documents for PCR. And I'm going to show you another example later on about how I write my notes. So I always start with the plan of care, the start of care, what date it was really done, the initial start of care. And in this case, it's April 16th, 2020. And the period I'm examining for its submission begins on August 14th, 2020. And you see the dates of the 30-day periods. I've got period 1 and period 2. I'm going to submit them in the same submission to save myself some time. A nurse practitioner for this Dr. Rand performed the face-to-face on April 25th, 2020. So we see that date is within regulation. I can see start of care was 4/16. The face-to-face was done on 4/25. That's certainly within 30 days after the home health start of care. So in this case, does the patient need a face-to-face certification attestation? So I'll let you think about it a second, and I'll have David go to the next slide. So when you're thinking about it, what do you know from the notes that I wrote? We know this is a certification because the start of care was in April, and this period began in August. So I know that's a recertification. But I also know I'm going to be examining the face-to-face and the need for a face-to-face certification statement for what was done back in April, because I always review even those old documents. I have to submit them. I want to be sure nothing was missed, even if I'm the one who looked at it before, which sometimes is the case. So let's see. So one warning I want to tell you is you may find a problem with a face-to-face or a face-to-face certification statement while looking at your research documents. Never assume just because the documents were previously affirmed that they will be affirmed this time. The reviewers at PGBA will look at each submission with brand new eyes, and they may have learned some things between the last affirmation that they did and this submission, that they're getting better at looking for the problem areas. So in this case, the answer to the question, does this patient need a face-to-face certification attestation, is yes, they do need one, but they don't need one for this episode. They needed one for that April episode. The reason is because the nurse practitioner performed the face-to-face, and a different practitioner was the one who signed the plan of care. He was the certifying doctor. So hopefully you're starting to sort that out if this has been a problem. Okay, you can advance now, David. So let's do one more test your knowledge exercise, because I do think that face-to-face certification issues really trip people up. So here's one. This start of care began on April 11th, 2020, and the patient, the current plan of care that you're examining is for PCR. It started on August 9th, and the plan of care doctor on the initial plan of care was Dr. Blaine, and the plan of care doctor on the current plan of care is Dr. Kruger. So when we look at the face-to-face document, Dr. Blaine performed the face-to-face encounter at an acute care facility on April 7th, 2020. And those are my notes. He's the face-to-face practitioner. So just think right here. Does this patient need a face-to-face certification attestation? So I'll give you 2 seconds to think about it. And David, I'll let you advance. Okay. So what we know from the notes on this previous slide, was that it was a recertification. The initial certifying doctor was the same one who signed the plan of care, Dr. Blaine. The face-to-face encounter was performed within the regulated time frame. But now we have this new doctor signing the plan of care, the current one that began on August 11th, I believe, or 9th, sorry, on August 9th. And do we need a new certification order since it's a different doctor? No. A face-to-face and a face-to-face certification order are a one-time requirement within the series of episodes from start of care to discharge. So just know that we don't need a new face-to-face certification order just because the doctor changed on our current plan of care. We'll send in the face-to-face encounter, and we don't need a face-to-face certification order because the same doctor signed, Dr. Blaine, signed both of them previously. So I hope that that's clear. Okay, go ahead and advance, David. Okay, so enough of that. Let's talk about the plan of care and see what problems can occur here. When you're reviewing the plan of care for submission to Palmetto, be sure all your required elements are present. And I went ahead and put the COP in there for your reference. You should know what needs to be included for a plan of care at this point. The reviewers are primarily looking for that diagnosis to support the services that have been ordered. And we've already talked about primary diagnosis. So look specifically at services and their ordered frequency and duration. Now, first of all, you should have some, there should be some correlation between the service ordered and your primary diagnosis, or at least some of your comorbidities. And that will be a judgment call. You must examine if those services that you've ordered with the frequency and duration will extend past the first 30 days, or that period 1 of your episode. This is important when you're submitting the second 30-day period, whether at the same time or in a separate submission. So some durations that are for 5 weeks may actually end prior to the second period beginning. And if you went ahead and included it in that second period, you might get a partial non-affirmation if the reviewer is really plotting out those dates. So just be careful when you're doing that. I typically look at the calendar feature in the software to see exactly when those plotted dates are against my period dates. There have been partial non-affirmations for missing interventions and goals. So also look at to be sure that your therapy goals have short and long-term goals, and that the goals are written in such a way that it shows complexity required of a qualified therapist. You don't want them written too simply so it looks like a lay person could do that. And then finally, look for, is there a practitioner or physician signature with credentials and a date? Okay, so let's now look at the strategies. You can advance the slide. For plan of care issues, it goes without saying that you must be sure that all elements are present. I recently was reviewing one where I was looking for the skilled nursing goals. They were completely missing. I was thinking, oh my gosh, this agency has never missed putting in the goals. And then I noticed in the pagination of the document that there was a whole page missing, and that would just happen to be the goals page. So make sure that all your pages uploaded correctly and that they're there. It would have resulted in either a partial or a non-affirmation. Again, if you're missing credentials, look at the practitioner, if their MPI registry, and print that page and just submit it with your documentation. I believe your best case scenario is to include your supporting documentation, which you remember is task 2 in your in PCR. You can do that by including a narrative of the patient's status and current problems to be addressed by the home health agency. It will go beyond the face-to-face and the diagnoses and complete any holes that were kind of left in that face-to-face documentation by that practitioner. So likewise, try to institute a practice of including a statement on the plan of care that says the physician or practitioner will include the agency-generated supporting documentation in their medical records. This makes it simple, and there are no extra documents for the physician or practitioner to sign when you include both of these elements in on the plan of care. Okay, you can advance. And I just wanted to let you know that Axxess software has templates you can use for various purposes, and there are also customizable templates. I just put in this example, which is, not from Axxess. It's just from things I've used in the past, just as a suggestion for your template. What is the primary problem? So the clinician can document what's the change from baseline to what their current issue is, and what functional and structural limitations do they have for their homebound status, what kind of help do they get, do they have to help them, who's able to help, and then any other pertinent information that you need. Okay, you can advance, please. Palmetto GBA has been embracing the use of International Classification of Functioning for several years now. And if you've not been using this method of documentation, basically it describes how the patient's activity limitations relate to their current disease, injury, or illness. And this in turn is why the patient needs services delivered at home. So there are two categories of ICF that will come into play in the e-services submission, and those are body structure and the body function. For simplicity's sake, think of body structure as changes in the normal structure of the body, like amputated limbs, use of oxygen, joint replacements, a urinary catheter, that sort of thing. And then when you're thinking of the body function, consider how the function of the body was changed from normal to baseline due to disease, illness, or injury. So in those cases, you're seeing things like hypertension, CHF, diabetes, anxiety, incontinence, even edema, anything like that. Okay, you can advance, David. So here's just a chart that follows the categories of function and the structure listed in e-services. And as I'm preparing to submit in e-services personally, I go down the list of diagnoses listed on the plan of care, and I check the appropriate functional or structural limitations. So just know that it's really common not to have any structural limitations, but to have, just several or lots of functional ones. So my best advice is to at least mark the ICF category that matches with your primary diagnosis, and then mark the others as they apply. But I typically, unless there's, 30 diagnoses listed, I'll just list the main categories, either function or structure that they apply to. This feature will allow the submitter, let me restart that. This will require that the submitter, whoever's entering that information into e-services, that they understand diseases and what body system is affected. So typically a clinician has to guide someone if they're not going to be the one actually submitting in e-services, then they're going to have to guide a non-clinician in these areas unless that person is very knowledgeable. Okay, next slide. So I wanted to wrap up with a few pieces of advice that I use daily in my own PCR submissions. First, I keep notes on every submission, and it's really mainly to keep myself straight. PCR submission is pretty much the same process over and over and over. And if you're doing many at a time, you will get confused on which patient you're working on. They all look the same after you've done several in a row. And what I like about the giving myself some notes, it kind of alerts me to abnormal things that are happening with the case, such as the need for ROC orders, resumption of care, or supplemental orders, particularly when I need a face-to-face certification order, and I'm looking to see, do I have an actual order for that, or is it in the plan of care, or what's happening? My notes help me kind of sort out what went wrong also if I get a partial or non-affirmation. So go ahead and advance, please. So I'm not certain everyone will want to adopt my formatting of notes, but here's what I do. I just wanted to kind of give you a clue, and you can work out exactly how you want to do it. I have a little notebook where I typically write 4 lines of information so I can get lots on a page. So on the left side of the page, I write my e-services login, a number that they send you. I usually request it by text. You can request it by email. But if you're doing a lot of e-services submissions, you're going to get logged out. It only keeps you in for 15 minutes. And typically what I do is I work one case start to finish, and it takes me more than 15 minutes to work a case. And so by the time I get back to e-services, I'm logged out. I've tried keeping myself logged in, but then that just adds clutter to my brain and I can't do it. So I just re-enter my login number. On the right side of the page, you can see I write the patient's initials. Since I'm working at home, I try to truncate the information just in case, I don't want to violate any HIPAA rules. I write their start of care date, and remember, that's your initial start of care when they first began home health services and they haven't been discharged yet. Then I list the periods I'm going to submit. So here's the first period is July 30th through August 28th, and the second 30-day period is August 29th through September 27th. And once I look at the plan of care, I write which services belong in each period. So here you see skilled nursing and PT were in that first period, and PT dropped off for the second period. So I'm only going to submit for skilled nursing in that second period. Then I list the information that I gleaned off of the face-to-face encounter. My first example listed in the first above those dotted lines, it was performed by a nurse practitioner. It was an office visit. The doctor, I truncated that. Dr. Rav is the certifying doctor, the one that signed the plan of care. And so I know now I have got to have some kind of face-to-face certification order. And in this case, so I didn't find it on the plan of care. I see it's in a supplemental order. Okay, so now you see that tilted box, that little rectangle. That's my version of how I mark things that I can't submit yet because there's a problem. In this case, on that top example, you see it says the face-to-face cert order isn't back yet. So I also know that it wasn't sent until October 21st. And when I was working on this, it was like October 22nd. So I knew it didn't have time to come back yet. I thought, oh, I'll just, maybe in a week, I'll go back and see if that order has been returned. So I know I can't submit that because I'm going to get a non-affirmation if I do, because that one part, the face-to-face certification order, is not met. So, and then you can see on the bottom part of it is a different submission. That's what I do, is I draw a little line. I couldn't submit that one. I go to the next patient assigned to me, patient initials, when they started care, that was last year. When I put in my period dates and my face-to-face, I saw that my little arrow moved, but I saw that Dr. War, W-O-R, MD, he saw the patient in rehab. He's the same doctor who's certifying the doctor who signed that plan of care. So my little arrow just shows that, hey, they're the same guys. And in that case, my little box says I was able to submit both those periods. So that's just how I use it. Okay, so now I know in a day or two, I'll go look for my UTNs and my DCN number that go with the ones I submitted. So you can adopt your own method, whatever works for you. But I just wanted to kind of, to just show you it's working for me and it might work for you. And one other thing I want to say before I leave that subject is I recently submitted 2 periods for a client, and it apparently got lost in the upload of e-services. I kept looking for the UTN and the DCN, and I knew I had submitted. I had ample notes that I had submitted it, but it never came back, and so I just had to resubmit it. Something happened, and it floated off into Never Never Land, which we know that happens. Okay, so now you can advance, David. Okay, so now you might laugh at this second tip. I already talked about notes are going to help you. But if you can't read your own handwriting, beware. I actually received a non-affirmation because I typed the wrong date into e-services. And I distinctly remember when I wrote the number 7 in the date, I thought, huh, that kind of looks like a 9, but I didn't erase it and change it. And by darn, when I went to submit it in e-services, I forgot that it was really a 7 and I entered a 9, and so I got a non-affirmation. I entered the wrong date. So I'm just telling you, I'm typically a pretty neat writer, but in that one, I totally fooled myself. And so now if I ever write a number and I think, oh, I really can't read that very well, I correct it for myself, because you know, you get into the e-services for submission, and I don't know, I just forgot. Another partial non-affirmation came when I didn't pay enough attention to my frequency and duration. So this was what I was saying before. I had a 5-week duration that didn't extend into the second 30-day period. I should have been more careful and really examined my calendar dates against my period 2 dates, and I just messed up. But usually you just need one really good mess up before you start remembering to not do certain things. Other partial or non-affirmations have come from services that have no orders and goals. And we've had that happen even with aid goals. There has to be interventions for that goal, for that service, and also goals for that service. So be sure you have those. And then my final word of advice, as it is ticking towards the end of this webinar, is never push the submit button on e-services until you have proofread your entries. When you go in and say that you don't have any more periods to submit, it will say, go ahead and submit. I'm telling you, don't submit. You need to scroll back up to the very top and make sure that all the entries that you think that you made were actually made. Sometimes the system is slow. You think you checked a box. It didn't check a box. So just be very, very careful. There's nothing worse than having to resubmit when you've already done it once. I just hate it when I have to do that. So there you have the very best of my advice, mostly on the mistakes that I have made since I've been making PCR submission entries to e-services. And I will turn this back over to David.
DeAnn and David, Yeah,
Yeah.
thank you so much for sharing your expertise and your advice and wisdom with us today. Don't forget, we will email everyone who registered for this webinar a link to the recording and the slides, and we'll also post them in the Axxess Help Center. If you have submitted a question, we will follow up with you after the webinar to get your question answered. And by the way, if you haven't checked out the new Axxess user community, I encourage you to visit it today at community.axxess.com. It's a great place to share information, ask a question, and connect with other Axxess users. Thank you all for your time today. Thank you, DeAnn and David. We really appreciate your time and the great information. I hope everyone has a wonderful afternoon. Thanks so much.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on software advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.